Hi, my name is Courtney Smalley. I am the ultrasound director at the Cleveland Clinic, and I'm here to give you a brief overview of procedural ultrasound. I have no disclosures, so we're going to run through some quick procedures with a couple of different objectives. First is we're going to talk about the different types of ultrasound guided approaches to procedural ultrasound. We're going to discuss the pearls and pitfalls of in-plane, out-of-plane, and oblique orientations, and we're going to explain techniques related to thoracentesis, pericardiocentesis, and paracentesis. So the two different approaches we're going to describe today for vascular access are an out-of-plane approach, which is a short access, or an in-plane approach, which is the longitudinal access. And we're going to go through these in relationship to central line access. So this is a short access of the internal jugular vein. And you can see in this video here that you can see a needle tip entering the IJ in the short access area. So this procedure, you basically want to center the vessel inside the center of the screen in a short access orientation, confirm the vein by compressing the structure, and identify the artery to make sure that you don't hit the artery. Some of the things you should be thinking about for short access approach is the Pythagorean theorem. So you can see in this image that A and B are the same distance apart, and this should help you orient your needle at a 45-degree angle to hit the vessel in the short axis plane. Some of the pitfalls of this from a short axis standpoint is that you can miss the tip of the needle, and so you will hear many of us say that while you're doing this procedure, we always want to see the tip of the needle. The pitfalls of the short axis approach is an increased risk of posterior wall penetration. You can get some reverberation artifact, and you want to make sure especially during the internal jugular procedure, that the artery isn't directly deep to the internal jugular vein. So some pearls for this is that it's easy to perform. This is an example of using the leapfrog approach, where you basically watch the tip of your needle and you use the ultrasound and move forward with the ultrasound as your needle advances. This is a courtesy video. So you can see that as you move forward and the ultrasound advances, the needle advances as well, and you make access. An in-plane approach is a longitudinal access approach of the IJ. In this image, you can see that the vein runs all the way across the screen and that your probe marker is towards the head. The pearls of this procedure is that you get to visualize the needle going through the entire procedure. You have less risk of back wall puncture if this is a vascular access procedure, and you just want to make sure that you are actually on the vein and not the artery. However, the pitfall of this procedure is that if you lose sight of the needle, you should stop advancing and find the needle tip, as you could easily roll from the vein onto the artery and potentially miss access. Here's a video. You can see the needle going into the vessel in the long axis plane. This is another video. Again, this is the wire inside the vessel to confirm access in the vein and not the artery, which is underneath the vein in this image. So, thoracentesis, let's get into procedures. Thoracentesis, we are going to talk about the diagnostic and therapeutic indications. So this procedure is normally done for evaluation of transudative versus exudative pleural effusions. Sometimes in our setting, this can be a therapeutic procedure to improve oxygenation or hemodynamic compromise and help with symptom control. Any of the three probes can be used for this procedure. You will need a thoracentesis kit, as well as a sterile probe for the ultrasound and a sterile field. This is an example of what one of the kits looks like. Two different types of patient positioning, so you can have the patient sitting up and leaning forward. The probe can be in the sagittal or the transverse position, and you want to look for the deepest pocket of fluid superficial to the lung. Here's an example of a patient sitting upright. On the right hemithorax, there's a pleural effusion. You can see it's pointing to the scapula and the effusion and where the ideal puncture point would be. When you lay the patient flat, you want to think about the anterolateral approach and the triangle of safety, which is bordered by the lateral edge of the pectoralis major, the fifth intercostal space, the axilla, and the anterior edge of the latissimus dorsimi. In this example, there's a left hemithorax pleural effusion, and you want to put your needle into the area of largest fluid pocket. For this procedure, the patient should be in one of those positions. You should identify the diaphragm, the liver, the spleen, and the lung. Again, making sure that you identify the liver or the spleen to ensure no solid organ injury. Mark the thoracic wall, make a small incision above the skin, and insert the needle just above the inferior rib to avoid the neurovascular bundle. Place the dilator and catheter and drain the effusion. Here's an example of a image that shows a pleural effusion with two ribs, the parietal and visceral parietal pleura of the chest wall and the black fluid behind it of the pleural effusion. And on the right-hand side, you can see a example of a needle going in under ultrasound guidance. The pearls and pitfalls of this procedure, you want to make sure for the pearls that you go where the fluid is. You look at the selected area in two planes. That's with any ultrasound procedure. You look for the neighboring structures, and this one, for example, the liver, the diaphragm, and the spleen are going to be the most important. You want to observe the site at the end of the respiratory cycle and note the distance between the skin and the pleural space. Pitfalls of this procedure is that you may fail to identify the deepest pocket. You want to make sure that the insertion point is above the rib of interest to avoid the neurovascular bundle. And lung is a moving structure, so make sure you look at the depth for inspiration and expiration. Next procedure we're going to review is pericardiocentesis. The indications for this procedure are a pericardial effusion causing tamponade, as evidenced by right free wall collapse during diastole, and this usually in our setting occurs during arrest or peri-arrest. The clinical signs are JVD, distant heart sounds, and hypotension. Either one of these probes can be used for this procedure, and you'll want to find a pericardiocentesis kit or an 18-gauge spinal needle. You'll want a sterile probe and a sterile field. You can attempt this in all three windows, subxiphoid, apical, and peristernal. This is an example of the subxiphoid approach. You're going to place the probe in the subxiphoid orientation toward the pericardial sac, potentially pointing towards the left shoulder. You'll want to insert your needle lateral to the probe on the right side and insert through the liver and toward the pericardial sac. Advance the needle until you see the needle enter the pericardial sac and confirm the needle tip is in the pericardium. Place the wire and dilate in the catheter and drain the effusion. In the apical approach, you'll place the probe over the chest, again with a sterile probe cover. Insert the needle lateral to the probe on the right side. Advance until the needle enters the pericardial sac and confirm the needle tip is in the pericardial sac, and then place the dilator and drain the effusion. Lastly, a peristernal long approach. The needle should be inserted at a 45-degree angle in plane to the probe on the anterior chest wall directed towards the effusion. Advance the needle until it enters the pericardial sac and confirm the needle tip is in the pericardium. You can use the ultrasound for confirmation. Pearls and pitfalls of this procedure is that you want to go where the fluid is. You can inject agitated saline to ensure that you are in the pericardial sac, and placing the patient in the left lateral decubitus can bring the posterior effusion forward. Again, in our situation, we're very rarely moving the patient around. Some of the pitfalls of this procedure may be that the peristernal long axis has a risk of damaging the left anterior descending coronary artery or the mammary artery, and additionally, the subxiphoid may lacerate the liver. The last procedure we're going to review today is paracentesis. Indications for this procedure is to drain fluid from the intraperitoneal cavity. You'd like to visualize the largest pocket of fluid to increase success. This is usually done when we're suspicious for SBP, evaluation of new ascites, or relieving shortness of breath or discomfort from large volume ascites. Either of these probes can be used for this procedure, and you should find a paracentesis kit, although sometimes in our setting we do diagnostic paracentesis. Windows and positioning. So one of the best positions is midline and about 2 centimeters underneath the umbilicus, or 4 to 5 centimeters superior and medial to the anterior superior iliac crest in either the lower quadrant, looking for anechoic fluid. In this image, you can see all of the hypoechoic fluid for drainage. You want to be at least 3 centimeters deep from the superficial skin to the bowel, and you should put color flow over the superficial areas to ensure that there are no vessels in the path of the needle. So for the procedure, an in-plane approach, you can identify other structures, sterilely prep and anesthetize the patient, and follow the needle using your ultrasound guidance into the intraperitoneal space. If you do an out-of-plane approach, you want to insert needle at the middle of the probe and follow the needle tip through the skin. Pearls of this procedure is that you can switch to the high-frequency probe and turn on color to evaluate for epigastric vessels. You want to identify area at least with 3 centimeters of depth between the peritoneal wall and the bowel, and look for moving loops of bowel in real time while performing the procedure. Pitfalls may be that you may misinterpret fluid, such as the bladder, renal cyst, ovarian cyst, as intraperitoneal free fluid, so make sure you look for landmarks. Make sure you put color flow to not lacerate an epigastric vessel. And patient may be moving, so make sure that you have appropriate landmarks. And that is an overall review of procedural ultrasound. Happy to entertain any questions.